I'm going to call this is part of a clinical trial we're doing, and clinical trials need acronyms. So this is the SAD trial after Sood, Aurora, Abdullah, and Delilah, who are my current fellows or just faculty members. But this is a clinical trial. It's very similar to what Ashok Himal showed. We can cure prostate cancer with surgery. These are the cancer-specific survivals from 3 different centers put together by Firas Abdullah. But patients pay a price, and the price is ED. A paper from John Mulhall looking at Memorial Sloan Kettering data from 2008 to 2015, and the potency rate was 17% at 1 year, 27% at 2 years. 30% of the patients were on ICI during this period of time. If you take the entire prostate out with the capsule, you are going to have a marginal improvement in potency. But if you preserve part of the prostate, or if you do focal therapy, such as Hashim Ahmed and Mark Emberton did, you could really have a wonderful potency. To do successful HIFU, you need to have a 5 millimeter margin from the tumor and a 5 millimeter margin from the nerves. So if you add that together, you can only ablate successfully patients who have a 10 millimeter margin. If you are able to do that, you can see that 26 out of 31, or 84% of men, had very good sexual function. While we were waiting to get FDA approval for HIFU, Aurora and his wife did a phase A study, a phase 0 study of the ideal stage, which is we looked at 100 patients that we had done radical prostatectomies on, who we felt were candidates for focal HIFU, and simply had Dr. Gupta, the pathologist, with the micrometer map where the cancers were. So this is very low-cost research. No patient was harmed since the prostates were out, and we were just looking at where the cancers were. And this was the distribution of cancer. What we found is that 78% of the time in patients with the bilateral lesion, there was cancer. Focal HIFU would have destroyed the cancer in 30% of the patients. Hemiablation would have destroyed the cancer in 50% of the patients, and we still would have left behind 54% of the patients would have cancer left behind, and 21% would be clinically significant or Gleason grade 2 and above. Much the same as Ashok Himal, we wondered whether we could leave a portion of the capsule behind and whether that would improve potency. And the reason to do this is because the nerves that maintain erectile function and urinary control are scattered all the way around the prostate. And some MRI studies that Ashutosh did showing that there were around 4,000 nerves around the prostate. It's impossible to remove all 4,000, but it's probably impossible to preserve all 4,000. The key to this trial was getting the informed consent, and a 3-minute video is given to the patients to look at. They look at the video, and this is an orange. Think about it as if this was the prostate gland. An orange has a peel, and an orange has the flesh of the orange. The prostate has a peel. We call that the capsule, and the prostate has the flesh of the orange, which is the glands of the prostate. Cancers of the prostate start in the flesh of the prostate, in the orange, if you will, and will then gradually extend out through the peel before they spread outside the prostate. The nerves that maintain erection are scattered through the capsule of the prostate. So, would it be possible for us to find an area of the peel that did not have cancer? And if we were able to preserve it, would we be able to preserve more nerves, and would that result in better function? And the answer to this is yes, yes, and yes. We can find out if cancer is in the peel by a fairly simple method, which is biopsying the peel. Look at the prostate. Most biopsies are done in 2D. So you just put a needle through the prostate. Can we biopsy this in 3D so that you can sample the peel more accurately? And this is what we do. So what we do, what we've used for doing the 3D biopsy is the Coelis system, which is you can see in the scientific exhibits. We then try to model what cancers we would miss. And very simply what we found is that if the patient had unilateral cancer, we would miss a cancer that is about 0.3 cc's in size. If the patient had bilateral cancer, we might miss a cancer that's 1 centimeter in size. So that's the natural distribution of the cancers in the pathological mapping we did. So you tailor your biopsy to try to not miss a 1 centimeter cancer, but allowing that you might miss a 0.3 CEC cancer. This is a take on a Shoke study, the total prostatectomy, and here's the seminal vesicle and the vasa deferentia. These are the nerve bundles that exist in denovius fascia outside the seminal vesicle. So you could see that when we quantified this in this particular patient, there were as many nerves in denovius fascia as there were in the neurovascular bundle at 5 and 7 o'clock. So if you stayed in this plane, you are going to preserve maybe another 1,000 nerves more. Shows that they stain for nitric oxide synthase. So all that is great. There's no difference between theory and practice, but what happens when you actually do the operation? So here are the controls, and this is the post-op IIEF-5 score at 4 months in patients undergoing robotic prostatectomy. So this is the pre-op shim, and this is the post-op shim at 4 months. If we had maintained potency in everyone after complete radical prostatectomy, this orange would overlap this. And what we found is that we were preserving potency, or 41% of the men were able to have intercourse, 26 out of 63 of the controls at 4 months after surgery. We encourage the use of intracavernosal injection, so this could be sham potency because 70% of them were on injections. When we looked at patients who underwent precision prostatectomy with the SAD trial, we have 69 patients. This is the first 25, and you can simply see that the preservation of potency is greater. The orange area is much greater than the previous study. 83% of the first 23 patients had a shim of 18 and above, and penetrative intercourse was possible in 22 out of 23. But this is subjective reporting by the patients, and there may be flaws in that. What we could verify is that every one of these patients per protocol was given a prescription for intracavernosal injection. So we can go to the pharmacy and see what percentage of the patients actually filled the prescription, and as opposed to 70% in the control, 9% filled the prescriptions at ICI. This now allows us to do a randomized controlled trial because we can use that prescription data as a surrogate for outcomes to see whether the potency works or not. Here are the PSA results. I expected that these patients would have a PSA of 1 to 2. They don't. The median PSA was 0.1. In summary, precision prostatectomy is a form of focal therapy which results in better preservation of erectile function than radical prostatectomy in my hands. In focal therapy, only the index lesion was ablated. In precision prostatectomy, all index and most satellite lesions are removed. We try to remove 95% of the prostate. At our institution, precision prostatectomy is being performed as part of a clinical trial, the SAD trial. Patients are continue to be followed with active surveillance, and if they have a PSA recurrence, they will have a protocol biopsy of the residual prostate tissue. A randomized controlled trial is being under review. I think it will get approved, and we will start in June with the randomization, which is the next stage of the IDEAL protocol. Thank you.